Hello, this is Brian Higgins, a registered nurse and a student with Capella University, working towards my Master's of Science in Nursing degree. This presentation is part of my MSN 6038 coursework, and my instructor is Dr. James Barnett. This presentation will cover literature, search, and review, as well as any practice guidelines for the current work within care coordination at the Minneapolis VA. Here is presented the clinical problem. There currently is a $5.2 billion expansion that's being presented to President Trump, who plans to sign that to improve the access to care for veterans within the community. This bill will add money to the Choice Program for Veterans Health Care. The Institute for Healthcare Improvement, or IHI, released a triple aim philosophy for healthcare, which is improved access to healthcare, improved patient satisfaction, and decreased costs of healthcare. This proposed plan will help to achieve IHI's triple aim and attempt to decrease the costs associated with post-discharge patients and preventing readmissions. The clinical problem is how to obtain triple aim. The major goal is to decrease spending. With the $5.2 billion proposal, that's for veterans health care nationwide. So how can the Minneapolis VA best use that money? Through the process of care coordination and using a transitional care coordination template, we can help to ensure that our veterans are receiving timely care and reducing hospital readmission rates, which will also help to decrease our spending. Our current practice is that veterans' hospital admissions are tracked and documented. However, there's little follow-up for this care. Veterans are responsible for reporting hospital admissions and emergency room visits, but that is for consideration for billing only. Discharge plans are reviewed, but the care is disjointed, with a lack of responsibility on who reviews those records, as well as ordering and coordinating any follow-up care that is needed. There are various factors that help influence this. As stated, there is a lack of clearly defined roles and responsibilities within the VA system. Another problem is the computer charting system. Charting system within the VA system requires access to multiple systems and programs and training on how to find information within those systems. With a lack of role definition, there's a potential for decrease in patient care. Many veterans depend on the VA system for their health care needs, and if these needs aren't met in a timely manner, then there's a threat that the veterans do not get the follow-up care that they need, resulting in another emergency room visit or hospital admission. Jones et al. Describes the need for clearly defined roles, and because of the poorly defined roles, there's a lack of follow-through on care that is needed. In order to fix these issues and improve veterans' access and experience, well-trained staff is needed to ensure properly transitioning patients from the hospital setting through to them returning home. Literature review shows all show that nursing is the key to successful care coordination. They act as the liaison between physicians and the patient. By setting this as the standard, the nurse can help coordinate the transition from hospital to home. Cipriano et al. Discussed the need for adequate documentation and use of Healthcare Information Technology System, or HIT, that can account for the work that the care coordination team does for each patient. Each article reviewed speaks to the need for nursing to ensure the timely access to high-quality, evidence-based care. Through all of the studies conducted, through both meta-analysis and retrospective pre-post studies with retrospective reviews, one theme remains consistent. Care coordination prevents hospital readmissions. One study, conducted by Naylor et al., showed that the potential savings of $439 per member per month for the 3 months of transitional care coordination with qualifying Aetna members. Currently, our organizational practice within the VA system, we have that standardized computer charting system known as CPRS, or the Computerized Patient Record System. This universal system allows for multiple providers to have access to the same patient's chart. Even if a veteran travels from one region to another, that medical record is accessible to any VA provider. However, not all care can be provided through the VA system, and many veterans often receive care outside of the VA system, either due to that service is not available within the VA, services cannot be timely provided within the VA, or they just simply live too far away. Other programs have been installed to assist with secure documentation with outside providers, secure communication with outside providers, resulting in electronic faxing of medical records through the use of programs such as RefDocs and WriteFax. A recent change to CPRS is documentation through the Consult Toolbox. This is a standard click-the-box sort of documentation in patient charting. Cipriano et al. Discussed the need for a standardized charting system that information can be easily pulled. Reports are routinely generated from this Consult Toolbox. However, one area that needs improvement is the documentation of care received. For example, if a veteran needs orthopedic care outside of the VA system, that information is often not clearly communicated to the primary care provider. Through care coordination, the nursing staff within the Office of Community Care will be able to review those records for any additional services and communicate back to the primary care provider, allowing for appropriate actions to take place, such as the ordering of any additional services, ordering of labs, scheduling of any follow-up care, and so on. Through the care coordination process, quality of care can be ensured. Continuing with the orthopedic example, these patients often require physical therapy after surgery. The care coordination team will be able to review the incoming medical records and ensure that timely post-surgical physical therapy is not only ordered, but scheduled. These clearly defined roles will help prevent a breakdown in communication that was noted by Jones et al. By ensuring appropriate and timely care, as well as reviewing records for needed services, the care coordinator will help to reduce the cost through ensuring evidence-based and timely care with community providers and within the VA system. The only way to know the true value and cost savings of this program is to conduct our own pre-post study with historic controls. In order to ensure proper care coordination for our veterans, there is currently hiring underway. More RNs, LPNs, and scheduling staff are currently being hired to help the approximately 700 consults that come through a week through our Department for Veterans who need care in the community, as well as the approximately 60 additional notifications for veterans who are admitted to community hospitals or emergency rooms. With a complex system that are needed for accessing and sending medical records, there is currently about an 8-week training period for new staff to the department. Updated training will be needed once new record system is implemented. The VA currently signed a contract with Cerner to merge our medical record system with the Cerner system. Lastly, as previously noted in other slides, a clear role definition is needed. Not only does executive leadership need to ensure that these roles are clearly defined, but also those roles need to be clearly communicated between the various care teams within the VA. Jones et al. Describes how this lack of communication can affect care coordination, resulting in duplication of efforts or gaps in patient care. The advantage to switching to Cerner for veterans' medical records, while an initial cost to implement, can have long-standing cost savings for the VA. First is that before anyone can become a veteran, they have to have served in the military. The current system used by the Department of Defense for their medical records is Cerner, which would make the transition from military to civilian life easier. This writer was a veteran and has experienced the difficulty of relaying 11 years of military medical history when making that transition. By using the same charting system, the information that is readily available and complete for the provider to review. Secondly, the current system being used by the VA is over 40 years old. Multiple patches and add-on programs were needed in an attempt to keep the system up to date. As stated earlier, there's the need to use RefDocs and WriteFax as well as the Consult Toolbox, and the WriteFax and RefDocs are two different systems that we use to send records to outside providers. By purchasing an all-encompassing system, this is the third way that an EHR like Cerner can save money. Training time can be cut down as new employees can be trained in one system as opposed to training within multiple systems. Employees can potentially go from learning to productive in a shorter amount of time when only one system is needed to effectively perform their duties. These changes will be keeping in with the Institute for Healthcare Improvement's goals for AAA. These changes are in line with the research conducted to assist with improving patients' health, increasing their satisfaction, and reducing healthcare costs by treating veterans in the community, reducing the duplication in efforts, and providing the care in the patient-centered medical home and out of other facilities. The VA's proposal to move towards a software program like Cerner will have an impact on patients, staff, and outside providers. By ensuring the sharing of information across multiple departments and agencies, there will be less back and forth communication needed. Outside providers will have better access to patient records without the need to call, requesting information, and waiting for faxes. Images can be instantly shared, which translates to no more needing to overnight images on CDs. This would assist in a more seamless transition of care between the VA and community providers, resulting in more timely access to care. This information has the potential to be shared both ways, meaning that as an outside provider sees our veterans, that information can be sent directly to the veteran's individual medical record, and again, not wait on fax machines in the records department or sit in an electronic fax waiting to be attached to the patient's medical record. There's the potential for a faster process for closed-loop communication from ordering provider to specialty care and then back to the ordering provider. There will be some changes needed to current nursing practice. As stated previously, when a veteran is discharged from a facility, care coordinators conduct 2-day and 30-day post-discharge phone calls to review the plan of care. The RN care coordinator makes a note and alerts the primary care provider to the hospitalization, the need for any additional services, and any new medications. There's no guarantee for post-hospitalization follow-up within 7 to 10 days, and a medication reconciliation happens based on discharge instructions from the discharge facility. As described by Lamb and reported in the study conducted by Pincus, transitional care coordination requires a lot of services initially after discharge. After discharge, a phone call from a registered nurse should be conducted within 2 business days. By the time of the phone call, the RN care coordinator has reviewed the discharge plan, along with any new medications that are ordered. A patient-centered plan of care can then be discussed with the veteran and then communicated with the care team. The veteran should be seen by his primary care provider within 10 days after discharge. Again, a plan of care should be reviewed, as well as further investigation into the medical history and ensuring accuracy of the medication reconciliation. One big change that Pincus discussed is that there's the importance of medical reconciliation. Pincus explains the importance of that reconciliation, stating that 66% of adverse events post-hospitalization are a result of medication errors, allergic reactions, and delays in necessary testing that's needed for some new medications, if indicated. This is also a change in practice, which is currently just a simple review of the list. The patient's actual medication history should be reviewed as part of the interview. When medications are taken, it should be asked when medications are taken, any association with meals and other medications, as well as any other important information that needs to be covered and documented. What is prescribed may not necessarily be what is being taken for various reasons. This interview allows the nurse to uncover barriers to care, and they can be identified as soon as possible to prevent further harm and potential readmissions. The research gathered and presented here support the need for care coordination. For the VA, this is particularly important as we do need to continue to support the health of our veterans, but ethically, we owe it to the taxpayer to be responsible with that extra $5.2 billion that's being given for veterans' health care. We have been granted the extra money, and through care coordination, we can spend it wisely and provide veterans with the care they need and the time that they need it. The next 3 slides just show my references, as well as the various studies that have been conducted and reviewed to compile this presentation. Thank you very much, and I hope you enjoyed the slideshow.